So maybe I can invite Jess and Thomas to the panel. Before we open to any discussion, I'd like to present my point of view, why I get involved with this collaboration. And I want to say that I've received a lot of requests from my patient about this program, about a ketogenic diet. So I want to just be transparent to talk about the pros and cons. On the pro side, I do see that there's good preclinical evidence like that this type of approach may have merits. The other thing is that we also recognize that during the pandemic, we all have gained a few pounds and my metabolic health has probably deteriorated on average. And so I think this kind of approach has a lot of potential merits to improving our metabolic health. On the con side, I want to caution our patients like not to overread too much at this point, because I don't think we have any evidence that if you implement this, you're going to slow down PKD progression. I think we really need more research and also making sure that we don't do any harm. I also want to caution the use of creatinine as a proxy of your kidney function, because your protein intake of slightly less than 0.8 gram is slight protein restriction, and we know that when you protein restrict someone, particularly who had been on a high protein diet, creatinine is going to come down, and it's a reflection of a reduction of lean muscle mass. And so by itself, I would caution that we don't overread into this as an improvement of kidney function related to PKD. That's why we also want to build in the research, maybe using non-creatinine-based measure in, so that we know, does it actually help to slow PKD? And I think I am from the skeptical side. I want to present a balancing view. And by working together, having a skeptic, it would make the research more credible. And if the results turn out to support your hypothesis, I think then you have a lot of credibility. And I do want to say that I also have heard a lot of physicians expressing their concern as well. So on the other hand, I have to say I'm very impressed by your enthusiasm, that your thoughtfulness, like putting a lot of effort into making this program. That's why I think it is very interesting from my point of view that you have a standardized approach, a lot of thoughtfulness putting in. So if we could test this really very good program, and I would just say that for the clinical trial that we have, that we are about to embark, we won't be able to answer whether this diet will slow PKD. I would be highly doubtful, but we would be able to answer, does it improve our metabolic health? I think, and also I think we will be able to also assess some of the potential safety parameters that may be very subtle. For example, like what is a change of lean muscle mass? And that's why I think we are going to bring Tim together when we do the MRI. Hopefully we could measure some skeletal muscle volume and to see what kind of changes during this. It's possible that you see some reduction of the skeletal mass to reduce. I think that is a possible scenario that may explain why the creatinine come down. It may not necessarily be anything related to kidney function. I have personally some experience with several of my patients who had PKD, also on either intermittent fasting, ketogenic diet. And some of them do very well on the metabolic profile. But I also have a couple patients whose total cholesterol went up to 10 millimole per liter, which is really, really high, and the LDL cholesterol. And then, so this couple of examples, just a counterbalance for all the favorable review you had. As one patient, she's enthusiastic and feels really good. but her LDL cholesterol is 2 times the normal upper limit. And I asked her, how does she achieve a ketosis? So each day she eat about this thick of pig skin with fat on. So she had a very high fat diet, but her LDL cholesterol also was very, very high. So I think that having a systematic and thoughtful approach, and I like the plant-based type approach and also healthy fat, I think is important. But we also have to be mindful this diet is likely going to introduce a mild form of protein restriction, which over time will have impact on the lean muscle mass and the creatinine generation, and that may explain the creatinine level. So I want to, but I do welcome this collaboration, because I do feel that if we're going to do research, I have to believe in it, and you certainly believe in it. You have stimulate my interest, right, to an area that I'm very interested. I want to find out, does it work? So we'll build in like some safety parameter, and like looking at like more carefully whether this potentially can impact on PKD. But this is going to be a pilot study. It will not be a definitive study. It will be underpowered. I don't think we will be able to address. I would be very surprised if there is any kind of demonstration of efficacy. I also want to mention that we purposely built in a control group, because many studies of this type don't have a control group, and using retrospective control is open to a lot of biases. And in this particular control group, I think we're fortunate in the sense that we have a cohort of like 500 patients we can draw on, so that we will match the dietary ketogenic intervention group with a cohort of patients who are just going to eat their standard North American diet, but they're going to be matched for the Mayo Clinic imaging class risk factor and age and sex. So I think that would be, and then they will get all the like tests that we do like the other group moving forward, so that we can have some really prospective comparison. I think that we will, hopefully we will learn a great deal, and I'm very grateful that Dr. Hori from Japan is very enthusiastic, and will use the same protocol so that we will have a greater sample size. I think we'll probably be able to do more than 40 per group, and like pending funding availability. So I just want to be transparent and present like my point of view, because I have to say I'm very impressed by your enthusiasm, by your dedication, and by your thoughtfulness. But I think eventually we have to also recognize transition from preclinical animal work to human has a very high failure rate. And so I think we have to be just a little bit cautious not to over extrapolate anything at all. I think this diet most likely will improve metabolic health, but whether it will change PKD outcome trajectory, we don't know. I think, and I think that's the motivation for me to take part and work with you. Yeah.
Just to comment on that, I really appreciate that, because I think, like I said, it's the tip of the iceberg, and there are more questions that will be asked that we don't know. And we want to be able to understand those as much as possible, so that we don't just have a good idea and then people can never implement it if it potentially does have benefit.
Yeah. We have a question from Dr. Jumino. A comment.
So my question is this going to be a randomized controlled trial, or is this going to be just a group of people who enroll, and then you're going to have your control that's not really randomized, but just people in your practice?
Yeah, so this is non-randomized. It's very hard to do a randomized control trial, and particularly with a time constraint. And so it would be kind of a prospective control cohort study. And but at least we'll try to match the major risk class using the Mayo Clinic imaging class and age and sex. Yeah. Yeah, yeah, yeah. Yes, Terry. Yeah.
I guess maybe a little bit along the same lines, because we've seen, I guess, in some other studies that weight loss is beneficial. Or so how like, so if people on this diet lose weight and then the other people don't, how are you going to separate out, weight loss as the factor? So,
Well,
you could just have people on a diet who are
so
going to
so
lose weight with any
I should just tell you a little bit more. In fact, the primary aim of this study is metabolic health. It's not PKD. So the secondary aim is readout of PKD related outcome measure. So weight loss is a primary measure. We want to see patient can lose weight and sustain it. And so
lose weight with some other diet,
yes,
and that might be equally
yeah,
beneficial. So
yeah,
that's why I'm trying to.
yeah, yeah. So I think it will provide some information whether this is. I think we can answer that in the 1-year study about weight loss and also improvement of metabolic parameter. We cannot, but we will piggyback some measure of the PKD. But there's a secondary outcome that it may help. And in the protocol, we specifically said that the aim is not to test whether it helps the diet help to slow PKD progression. But the secondary aim will be helpful in a sense that it will generate some information that may allow us to see potential effect size, how many patients you may need for sample size calculation if you do a randomized control trial using a similar approach in the future. So I think we are very transparent. I don't think we can claim that we would be able to answer anything related to PKD progression, but we will be able to answer the safety and tolerability and any adverse event, which I think is a big concern, because I don't mind recommending this to our patient to improve their metabolic health, if anything, and I think it's very possible. But what any downside risks do we know that? I think in a controlled manner, we will be able to address that. Yeah. So that's the primary goal, is to really look at the metabolic health and potential risks and side effect of the.
Are you including the keto citra as the supplement or just the diet part?
It's the whole thing. I'm going to test the whole program.
Okay. And so the one thing my one concern about the keto citra is the amount of potassium in that. Because so are you?
We are not testing late stage CKD patients.
Okay, got it. Okay, because
So this a part of my I think we discussed that in a KDIGO meeting. Like we really lack a lot of guidance, dietary guidance in the ADPKD patient who do not have late stage chronic kidney disease. Like many of our dietitians can give very good guidance of people with late-stage chronic kidney disease, basically restricting their diet. But many of these patients who have fairly normal kidney function and or maybe mildly impaired kidney failure, and we really want to promote healthy lifestyle diet, not a CKD late-stage diet, because they are working opposingly to the healthy diet with all these restrictions. So that may generate some new data about what would be a healthy diet. Yeah. So I don't think that this trial will really address whether this dietary program will slow PKD. It's a step toward building more evidence, providing maybe subsequent research. But what will hopefully help, from my own very selfish part, is can I look in the patient's face and say this is safe, and if I tell them you're going to embark in this program, what are the potential risks? Maybe certain percentage of patients may have some side effect, and what are those? So I think in a controlled manner, at least we will get some idea. So that's what I hope to get out of this trial. Yeah.
Maybe just one quick thing to add, Terry, to your question, whether obesity or weight loss is involved. I always think that's actually a good thing. That's not a bad thing, right? So if someone who is overweight and obese is able to lose weight, and that's certainly part of the program as well, to help people accomplish this. Being in ketosis at least part of the time is sort of almost a necessary requirement in order to actually lose fat weight. And I think it's been shown over and over again that low fat diets, which means high carb diets, are essentially almost ineffective in losing weight, or very difficult to make them work. Whereas ketogenic diets are very highly effective in that. So one other aspect is that I'm actually very curious about potential differences or similarities between the two sites here in Toronto versus in Tokyo. I would assume that patients in Japan are probably a little bit less overweight and obese on average. And I think it would be very informative to see, does it still work? If somebody doesn't start out obese and overweight. Yeah.
No, I think maybe I didn't make my point clear enough. All I'm saying is I think weight loss is great.
Right.
We know that, but there are many different ways to do it, right? I mean, that diet and that supplement are not the only way. I mean, if I take on an intensive, let's say, exercise program and maintain my diet or cut my calories down by a little bit, I could also lose weight. So that's my point, that there might be many ways to lose weight. And if weight loss is like the primary effect, there might be many ways to do it. That's my only point. Not that weight loss would be bad. I mean, I think we all know that being obese isn't good, whether you have PKD or not.
I think what we hope to get out of this trial may be some information that may inform the PKD community of one approach of improving metabolic health, and what are the caveats. Okay, because I think right now there isn't any control information. There's a lot of anecdotal information. And so in this trial, like the primary outcome, we're very specific. It's metabolic health. The secondary outcome, we said that we will try to collect some information about changes in kidney function and kidney volume, which may be useful for future planning of like randomized control trial. So we're not trying to answer that. And I think we also want to, one thing I want to learn myself is like maybe using non-creatinine based kidney measurement to really, because I'm actually a bit skeptical about the creatinine. I think that we need some independent measurement. Like we'll also be doing creatinine clearance too. But the problem is if you're not in a steady state, it also is very difficult to look at clearance. But we will be doing multiple, like 24-hour. So maybe the beginning and the end, like 1 year later, the patient would be in steady state. The creatinine clearance would be also very interesting. And but we're doing cystatin-based type of measurement. I think it is important because I think it's very easy for a patient who read from the internet your kidney function suddenly better. I'm very doubtful because for this disease, I mean, I look after the patient. It takes like many years for the kidney to change. Like and then unlike the animal model, some of them like the results are very quick. So I think that I'm just not sure the kidney function measure is reliable, and I think we will generate some information, and maybe that will help us for the trial design in the eventual, like if we're going to do a randomized control trial, because you'll be changing lean muscle mass at the same time. How do you deal with that? And I don't think we can actually just look at eGFR and take it at face value.
On the EGFR question, I totally agree. It's not a great marker, especially if you're modifying protein intake. But I should point out that the study in Cologne was not a low protein diet. So that was just a regular ketogenic diet. And the same for the retrospective case series study. This was just like random ketogenic diet that people were on and would actually have been high protein diets for most of them. And still it led, the direction it went in was improving EGFR values. So just to put that out there, that I agree. You know, we have to look at other markers as well. But so far, I wouldn't say that all the data just simply says it's just a protein intake.
Yeah, I think we need control data, not anecdotal data. And I think the other thing that we will build in is some kind of an inflammatory marker profile, like to see whether this diet, I suspect it will have some effect, but I don't think, so I think we will have some of the question we can ask, metabolic health, I think we'll get some idea, but PKD, I don't think we'll be able to answer from this trial. So I would also advise all the patient, like on the internet, like that just, if you want to take this diet, I think I would encourage you to enter into the research trial, because that's the best way to generate data, and not to do it on your own, especially unsupervised. I think potentially there may be possibility of harm that you may not recognize, and you do it for a long time. So that's my.
I have to applaud you guys, because I think that is the way to go to get more data, because otherwise there's a lot of us out there who are skeptical, and that's exactly the reason. So
Yeah.
I do think that the approach you're taking, I have to applaud you. I think that that is the way to go. That'll make us, as you said, be able to say, yes, we think this is safe. Even if we can't maybe answer the efficacy question, at least we can say, yeah, there's no harm that's going to be done. So.
Yeah, I mean, I have gotten to know Thomas and Jess through multiple Zoom meetings. I'm very impressed by your enthusiasm, and certainly you believe in your research, and you work very hard. And I think this is a great collaboration. And I just want to temper with the other side that I want to be your counterbalance. I want you to convince me through this research. And so that's why we want to work together. And I think we have a good relationship, and we are able to disagree and yet still work collaboratively. And I think for the better of the community. And I think Dr. Horry, I think he's a firm believer, but I think he also need to be convinced, and because he's doing the intermittent fasting himself, and I think there's certain potential for confirmational bias, because people who are doing this, they are not your ordinary general population. They have a certain lifestyle that propel them to take a certain kind of dietary approach, and so I don't think we can generalize to just a general population, and so I think that having a very controlled arm, and because I think the group of patients who are going to take part in this trial, they are not your ordinary ADPKD patient either. They have certain belief. And that's why it's very hard to do randomized control trial also, because you say this is going to be a randomized control trial. And then many patients say, well, if I'm not in the treatment group, I'm not going to participate. Then you will have very hard to recruit the other side. And so as a compromise, we come to this design. At least we will have the best control group as we can assemble at this time. And they will undergo the same maneuver, and then see, and then we will build in certain things that some of the questions that are of concern, can we allay that, and with results, and so I think that I'm very excited to work with you, but I also want to be transparent, and just that people know, because obviously there is also perception of potential conflict of interest, and but I do think that you believe in what you're doing, and which I really respect very much, and you put in so much work, and I would rather work with a program that have already worked out so much detail, and so this is really as good as you can get. So let's see what the results showed, and yeah. So do we have some online questions? So first question, in order to engage patient involvement is transparency. From a patient family point of view, it is very difficult to get full picture from the doctor. as the speaker mentioned, the doctor spend 90% time to put the notes in the computer, but not the person. And those notes only end up in a system, never share with anyone. This may be issues to release those notes, but I hope it is helpful and encourage the patient and family to be involved. I'm not sure whether this is maybe in response to the previous talk, but I also think that it has some application to this trial. I think we want to be very transparent. The trial that we are doing is partly funded by the CIHR, a federal government agency. But given the funding difficulty, we also appreciate that, like Thomas provides some of the keto citrate food free of charge, so that it decrease our costs, and so it's really a true collaboration. And I think both of us really want to know like what is the effect, and I'm very excited that we have this share kind of a willingness to find out the truth. Right, the truth may or may not be what we like, but at least we put it through the scientific scrutiny. Yeah. So how to enroll this program? I think we have to get through REB still. We'll be working on it, and probably in the early spring we'll be advertising, probably through PKD Foundation of Canada, and for this Canadian trial. The Japanese group, they're doing the thing, but we are sharing the protocol exactly the same, so that we will have higher number, and Dr. Horry also has some suggestion about additional tests, so I think that hopefully we will learn something very useful to inform us. I think at this time you should really consider this as research. If you are thinking that the diet actually has a potential to modify PKD, if you think about it to improve your metabolic health, then I think there's very good likelihood that they will have this kind of effect. But the point about slowing PKD progression is a different question. So I think we have to be transparent to say that at this time we don't know. I think we will have to accumulate more data over the next few years.
Just to add one more little thing to the question how to enroll. So to actually enroll into the clinical trial, one would have to be in the kind of Toronto area, live around here, right. Or in Tokyo. However, anyone can enroll in the Renew program that's currently offered in both US and Canada. And that's independent of the clinical study. So but if somebody wants to be in a clinical study, they would have to be local patients. We're also actually planning to essentially have the Renew program become a continuing, ongoing clinical study where patients that enroll in it can just choose to also participate in a clinical study. So that's something that's not up and running yet, but hopefully we can get this done where patients can just be monitored on an ongoing basis. I think Terry.
If they participate through you guys in a clinical study, do they get it for free? Because it's
they do get it for free, right?
Okay,
yes.
so everything,
right.
including in that your clinical study, but Thomas, you mentioned that
in the Renew program.
Yes.
Well, if we had the funding for it, yes, but that's currently not the case. So we may have to just do it the normal way, where people just sign up for the program and just essentially as an add-on say, okay, I will fill out surveys regularly, and you get the blood panels. So it'd be fantastic if someone like the PKD Foundation wanted to fund this as a study where patients actually can participate for free, but we currently don't have that.
Okay.
Yeah.
So there's a few online questions. One of them deal with the sustainability of the keto diet in PKD long term. So what is the longest term that of the non-study patient, like non-research study patient?
Yeah, this is number one question even for our patients.
Yeah.
So the sustainability ultimately depends on how you implement it from the beginning. And so on our side, like I said, we have patients who have been on it for far more than a year, and they have turned it into a lifestyle. If it's a diet, they likely won't stay with it for forever and ever. And if they're not going to, then we talk about what else would you do. But when it becomes a lifestyle, people will stay. We've had them on it for more than a year and been fine. Like I said, it ultimately depends on if you can personalize it to someone's real life and their lifestyle and how you're going to implement it in that way. And also for people to make some space for healthy food in their life. Because if you are so busy that you don't have time to take care of your food, then you are at the mercy of what is offered that is fast. And like fast food, whether it's ketogenic or not, is not healthy. So that's where the lifestyle part of it comes in. People make some space, and once you have that lifestyle, it's quite sustainable. So
maybe just to add one quick thing, sustainability, I think is really critically important in any diet and lifestyle intervention. And I think, as probably you all know, if you tell a patient, reduce your portion size, exercise more, and come back in half a year, exactly nothing will happen. So that's pretty much never works. And I think the program that Jess and her team have set up really addresses this, where patients really go through a 3-month program. They learn the ins and outs of why they're doing it and how to do it. They get all the tools. They have online tools. They're measuring their own blood glucose, blood ketone levels as a feedback. They know how to handle all this. They learn how to deal with difficult situations. So when you go out in a restaurant, if you're in a social environment, how do you actually deal with all this? So those are all the kind of things where people tend to fall off a wagon if they don't have all that education.
So there's a couple of comments about bloating, hyperkalemia. So I guess you probably have some anecdotal experience, but we will also build in the trial like parameters that we will track for this kind of symptoms, whether there's improvement in one group versus the other, whether hyperkalemia actually occur in this group of patients that even though they may not have advanced kidney failure. So I think that kind of data will be more informative, like more evidence-based, to really give you some kind of percentage risk, like is it any risk at all, or whether it is safe, that you don't really see it within the framework of the patient population.
Well, and I say, and also to both of those questions, people that come in to follow a group program approach, we don't service everybody because it's not appropriate for everybody. Some people need to have one-on-one. If you are hyperkalemic, you actually are not allowed to participate in Renew. It's an automatic elimination because we can't provide the diet therapy in a group fashion safely. So you work one-on-one with a dietitian. You can follow a lower potassium diet if that's what's driving, if food is driving your hyperkalemia, even though evidence doesn't necessarily support food is the main driver of hyperkalemia. If food is the driver, then you work one-on-one to follow a lower potassium type approach. Same with any gut symptoms. We really try and screen that out before people start, or even if people come to work with us privately, we wouldn't even start a ketogenic approach until we address significant gut symptoms first. So having that clinical perspective and that clinical experience when patients have, extraneous circumstances or symptoms, I think is really, really critical when you implement this. So that's why, again, like I mentioned, you don't want to be dogmatic in any one way, because nutrition is pretty intimate for most people. It's so personal, and it touches into a lot of different places.
Did you have a comment, Tim?
Not a comment, but another question.
Yeah, sure.
If there's any. So probably a naive question for Thomas here, but I was curious about the uric acid diet. So you showed the results on Peter's heterozygous mice. One question I had was, what are the impacts on wild type mice with that type of diet? Obviously, it's inducing some form of kidney injury, and just curious about that impact. And then I was wondering, with the the kind of central hypothesis about the microcalcs forming, the stone burden. So can you comment what's the mechanism for, say, non-PKD patients that are still stone formers, and what's causing them to not process or shed the stones? I'm just sort of curious about the mechanism. And then I think the last question is, if stones are really a burden only for a subset of PKD patients, do you anticipate that you will see benefits across the board, or is it really a subset? So, sort of long-winded question.
Okay, lots of questions. Let me see if I get this all straight. So, with experimentally, we actually do this in rats. If you just take a wild-type rats, you challenge them with the uric acid protocol. You can actually fine-tune this and make it a reversible challenge, where you wash it out and they recover completely, or you can drive it all the way to chronic kidney disease, and you can actually use this as a model for chronic kidney disease, and that relates to things like gouty nephropathy, which as you probably know, people with gout, very high uric acid levels, they have a very high chance of developing chronic kidney disease. Something like 80 to 90% of them eventually end up with chronic kidney disease, which I think is quite underappreciated, because, and I think that has to do with many things, such as gout is usually treated by rheumatologists and not by nephrologists, and they don't necessarily talk to each other. But anyway, so other types of kidney stones, even in just the general population, I think you asked about what are the mechanisms, and I think that's exactly what our kidneys evolved to, is how to deal with these microcrystals that actually occur daily, and we all pee out sometimes millions of crystals all day long. That's just a normal part of how our kidneys are designed and work, and they turn on these signaling pathways. They can dilate. It goes back to normal, and only if we essentially overburden the system by eating, by drinking a spinach smoothie all day long, for example, then you can have those problems leading to even something like acute kidney injury, or in a long-term setting to a potentially chronic kidney injury. So yeah, and whether in PKD patients that are not affected by kidney stones, whether that still plays a role, I think was one of the big questions. I would argue probably yes, because the kidney stone is really only the end result of potentially years of abuse of the kidney, if you will. And long before you get a macroscopic kidney stone, you still have thousands and millions of these microscopic crystal just floating around and forming in the kidneys and doing their micro injury. So I think that's a very persistent type of injury that just happens all day long, and is very often influenced by diet, without people even knowing about it. Right? So I know people that love dark chocolate and eat this all day long, not knowing that it's very high in oxalate, for example. So I would say there's some easy things to do to just reduce the risk on a sort of ongoing basis.
That was great. I think that largely answered everything. I'm curious then, if you can induce CKD, are you also seeing cystic burden in wild type mice? Are you inducing cyst formation, not just in,
Right.
For example, the heterozygous, but in,
Right.
wild types, for example?
There's actually some interesting research from your neck of the woods, from Christian Hanna, who just published a couple of papers on a couple of genetic diseases that go along with a sort of a persistent crystal burden, where they're seeing that this not only forms microcrystals in the kidney, but also leads in the long term to cyst formation. Which is kind of like the human experiment to say, yes, if you just have persistent crystal burden, this can lead to cystic disease. And I think yesterday we talked about, some sporadic simple cysts that are actually very, very common in people with at a certain age. If you're, whatever the cutoff was, if you're above 50 years old, chances are you have some cysts in your kidney. Where do they come from? I would speculate that this might have something to do with that type of crystal injury.
I just have a couple of comments. In the trial, we actually will include like urinary lithogenic profile so that we can also track all the mineral and all that, oxalate and all that. So hopefully learn a little bit from it. I don't know if Jess want to comment for the ketogenic diet. Do you have any threshold of kidney function or kidney failure level that you would be concerned of, like of a patient like taking this, particularly for the risk of hyperkalemia?
Yeah, good question. So in the Renew program, our cutoff is a GFR of 25. But working one-on-one with patients, our second patient to walk through this approach one-on-one, his GFR was 6. He worked in an industry where literally if he started dialysis, his career was done. Worked in the movie industry. So it was his Hail Mary. He's like, can I just try this before? And he otherwise felt, he had some uremic symptoms, but he said, like, let me just give this a go, because if I can do this and not lose my career, like, let me try it. So, and again, it's just anecdotal, but we worked with him, and he followed a ketogenic diet. It reduced all of his uremic symptoms, which maybe some of that was the protein reduction as well. And it was able to maintain him for a year and a half. And we actually pulled him off of it and went to a very low protein diet with keto analogs temporarily. And some of his symptoms actually returned, and swelling returned. So we went back to a ketogenic diet, and he was able to maintain his function until he got to transplant. So I don't think there's a GFR cutoff, but if your GFR is low, you must have some professional help, and you must monitor it very carefully. And that was done in collaboration with his physician. And for him, that was the right approach for him to, on the other side of real life, he still needed to have a livelihood for his family.
Are there any other questions, Winnie? Well, I answered the bottom one. Can you scroll? No. Does the high level of mineral, vitamin supplement needs act as a barrier to a patient's adherence? I think this is referring to your ketogenic diet.
I don't think it is. People are pretty used to taking a daily multivitamin. So daily multivitamin, if they choose to use Keto Citra, they do it, twice a day, and I don't think that's a lot. So at minimum, they have those two, but I haven't found the supplements have been a barrier at all to people following it.
And then how does this approach translate or incorporate cultural, religious diet or dishes?
So again, that it depends on the patient, and that's why we have a dietitian built. I mean, in the Renew program, they have a dietitian that monitors them, or one-on-one. In a group program, there's only so much personalization that you can do. But that's why while we provide tools like a meal plan or different types of foods, we also provide the why so that people can adjust things as they need to. And so you could come in from a different culture and learn the principles and adapt some of the things that we're doing to your life. But we don't, within a group program, it's too hard to personalize to someone's specific culture. Although, again, they have that dietitian, it may just be a few tweaks that they need to work through.
One quick thing, so the implementation of the Renew program in other countries can be easy, depending on what the country and culture is, but can also be really difficult, like Japan. So Jess actually just hired a Japanese-American, or is about to hire a Japanese-American dietitian for the purpose of translating everything and adapting all the recipes, with completely different ingredients, and even Canada versus US, where everything is either in pounds and cubic feet versus metric. That's, a little bit of a change, but I think, everything can be adopted for sure.
Okay, so there's another question about creatinine. So it says creatinine can bounce around based on hydration, how much protein eaten, exercise, and muscular profile. Is there a more accurate way to estimate current kidney function? So there is another way using cystatin as a non-creatinine marker. It's not a perfect way, but it's another way to assess kidney function. And I think the newer kidney function equation will be more based on using that and also the creatinine. And I think the issue about using creatinine in this type of trial is not a trivial one. I think it is because like when you change muscle mass, then it takes a certain steady state in order to be able to interpret the creatinine even after the change. And so I think, but hopefully we will learn something from this trial. And so the answer to this question is it's a new approach, but I think you have to wait for further evidence. And anecdotally, some patients in sustained ketosis can have higher serum glucose level. Is that bad given the finding of PKD cysts flourishing with glucose? Are there any endocrinologists studying this phenomenon? It's very hard to find information about it. I think this is very hard to answer. Glucose changes so rapidly, and it's really sustained state that probably will have any kind of impact. I think this is a very difficult to answer. I'm not sure whether sustained ketosis may be associated with high.
Well, so there's a little bit. So what happens if you're on a keto diet? Let's say your ups and downs, your daily ups and downs of blood sugar. Just everything gets flatlined. Insulin sensitivity usually greatly improves, and that can lead to essentially your body running on a highly efficient mode, where even small intake of carbohydrates essentially doesn't get used very much, and that might lead to an elevation in the baseline blood glucose levels. I think that happens in some people, not very often. Usually you don't ever see these spikes and followed by spikes of insulin, so that's not a thing. But I've heard a little bit of the that it can happen that somebody becomes so insulin sensitive and that they're that it can have an elevation in baseline blood glucose, which I don't think comes anywhere near to what one has in a just daily life high carb diet. We have these enormous spikes up and down.
There's a good question, I guess, is are there any good clinical study or randomized trial results of ketogenic diet in metabolic health in a normal population?
So there's actually a company out of the San Francisco Bay Area, Verda Health. They're using ketogenic diets for reversal of diabetes and metabolic syndrome. And actually the question is, what is a normal population? Right? So if you think about it, I think over 50 to 60% of the US population has a chronic non-infectious disease these days. And that mostly includes overweight, obesity, metabolic syndrome, and so on. So the normal state is almost that state these days. And certainly probably the vast majority of people that walk into a doctor's office fall into that category. So they're probably the normal population these days. But these studies, there are studies that have been done and published, and I think they're getting more and more almost by the day. Where these low carb dietary interventions have only shown benefits so far.
Just one other comment. When we were working on developing this, we worked with Beth Zupak Kenya, and I should have put her on my acknowledgements, and I missed that, from Charlie Foundation. And she has been not only working with ketogenic diets, but working in the research on ketogenic diets for over 30 years. So this, like, she is the expert of experts there, and she's been a really important mentor for us, because that was one of our questions. We looked at how has ketosis worked in other populations before we bring it down to a population with kidney disease, and kind of fleshing out some of those questions with her was part of the process of developing this.
No, I think the question is, are you aware of any good control study in the general population with ketogenic diet that you can provide a reference or something? Like
I don't have a reference off the top of my head, but
Okay.
there certainly are some out there. And yeah, and that my comment there was just that there are studies and people who ketosis is all that they do, that that they have some work out there.
I think that's the last question. Okay. Any question or comment from anybody else?
So this, hello? So this question is about sustainability again. So I'm just wondering, how is it costly? Just a curious question. Is it costly for patients to maintain a ketogenic diet? I'm just thinking about the inflation right now with food costs and everything being so expensive, and having like the healthy fats, fruits, vegetables. It's very expensive. So I'm just wondering, how sustainable is that for patients, and can they maintain that for the long term?
Yeah.
Especially for those who are low income.
Yeah. So maybe to back that up is, what would you be trading off? Right? If you say, oh, this is too expensive, so I'm not going to do this. And like, to that point, when it comes to food, expense is generally related to how much time you are willing to put into it. So people want everything to be fast and also super fresh and convenient. And the truth is that sometimes you can find that magic spot, but generally food is cheap because it's preserved. And so you can make a lot of it, and then you can sell it as you need to. And so, I mean, if you just think about, we talked earlier about resource allocation in a hospital, we also have to decide what our resource allocation is toward our health. I wouldn't say it is more expensive than a regular diet, depending on how you decide to do it. And again, that's why you have a professional that can work through that. If you say, wow, like my grocery bill really went up. And that's one of the questions that we worked through with our patients. And some of them commented, yeah, my grocery bill went up. But my grocery bill went up, this is too hard. That's something you can work through with a professional and be like, well, like, what are your go-tos and why is that costing you a lot? And maybe can we swap it out with this, which is a little bit, doesn't cost as much. So you can personalize the cost, but I think also there is the, on your own side, on the personal side of the patient, they have to also realize that they're going to have to make space in their time. They're going to have to make space in their life for food. And I mean, that's not an unreasonable expectation for any of us to step back from our life just a little bit and say, wait a second, like, where are my health priorities? Because I can't have everything fast, everything easy, everything, and have it without some cost also be, very healthy as well. So, but I think it's doable for other people. And there are people that it would not be appropriate, and I would not recommend, based on maybe where they're at in their life, not just economically, but just with stress and other things. But that's, I think that would be the same situation for medication or any intervention, is that you're still looking at, you don't say, oh, don't take this medication because you might not take it. You still recommend something if you think it potentially will impact their health. It's the same thing with a nutrition intervention. I think you can do this. Let's see if we can find the support to do as much as you can. And if you can't right now, you will have a space later, but they're informed and have a choice.
Actually, one more thing to add, and I think that's actually a really great question, and lots and lots of people are asking that exact same question. You know, how can I afford a healthier lifestyle? I can barely buy the bad food I'm buying right now. Actually, Jess and I have a live show Q&A coming up next week. I want to say Tuesday, something like that. So people are welcome to tune in. But we want to discuss exactly that question. I think one thing to keep in mind is most people eat, of course, too much food, right? So so if you just simply cut that down, can probably cut your grocery bill in half by just eating the appropriate amount of food. Another thing is, I don't think it's necessary to buy everything organic and everything, in the fancy grocery store. And I've actually, I like to be my own guinea pig and practice what I preach and so on. So I've done, all these types of ketogenic diets and time restricted and intermittent fasting just to try it out. And I found I actually probably end up saving a lot of money at the end of the day because I don't buy all the expensive restaurant food anymore and cafeteria food and all these kind of things. So I think it's very doable for people with less income. It might actually at the end of the day actually save some money, and it's really not necessary to buy at the fancy grocery store and everything organic and so on.
I think it's a very important issue because the inequity is very real, and I think that many things that the reality it is a very challenging time. Like many people, for example, at U of T, actually, in this building, there are students who have food insecurity. It was on the news. So they have enough money just to pay the tuition, but they don't have enough money to pay for the food. So there was a group of students who used their unused food credit, donate into a bank to help to subsidize those patients. And it is very expensive. And on the other hand, maybe one have to be creative. My daughter liked to create this healthy food, but she would make one batch. And if you don't mind eating it 3 times per week, the same kind of food, like it may also cut down your time of preparation, and you can make it like so. But on the other hand, processed food is cheaper but less healthy, and that is the reality. There's some kind of compromise in between, I think, and would be very helpful. So I think we are close to the end. I don't know if there's any question or last comments. Anyone? Yeah. Just maybe speak to the speaker.
Is exercise recommended along with the ketogenic diet, I wonder?
You want me to go first? Okay. Yeah, so exercise in of itself does burn glucose. And so it's very, it's very helpful for sure. We have a lot of people that come in and want to exercise. We have some people that can't, whether because they have a hernia or, we have some situations where people can't, but 100% we love being able to include exercise because it expands people's carbohydrate load also, which they also really like. So, exercise is so important for probably any part of health, just like food. It's just our bodies are meant to move.
So the saying goes that you cannot out-exercise a bad diet. So I think the number one step is probably first fix the diet and then add exercise on top of it. If somebody sticks with the same bad diet and just says, oh, I'm just going to exercise more, I think it probably has very little effect at the end of the day. And that's probably what the experience has been from lots of people. They spend all their days at the gym and they never lose an ounce of weight because they didn't fix their diet first.
Okay, so I think that probably wraps up the conference, and I thank everybody for taking time from the weekend to this very interesting, stimulating discussion. And I know that diet is a big interest for our patients, and I just want to provide that this is a promising approach, not proven, and I think there's a lot that we need to learn in order to provide some kind of evidence-based guidance, like moving forward. And So thank you very much. Have a nice weekend. And again, I want to thank Winnie Jackso and then the AV team and for making this possible and a lot of hard work. And so thank you very much.